Hi, welcome to the American College of Cardiology 2026. My name is Manesh Patel, and I'm excited to be here with a colleague who's also helping us with the American Heart Association meetings and a friend as we think about research that's being presented here, some important topics that we wanted to update you on. Brahmajee, I was going to ask you to introduce yourself, and then we'll get into it.
Hi, Manesh. So Brahmajee Nallamothu, I'm a cardiologist at Michigan, and I know Michigan and Duke have some big games on today. I've been tracking along.
I hope we get to play.
It'd be a great rematch there, but we'll have to see. How's the meeting been so far for you?
Great. You know, all these meetings are invigorating because you get to spend time seeing people, connecting, and then, you know, learning about new science and in the middle of March Madness. So it's always exciting to do that. So I'm excited and had a good meeting, and, you know, hopefully we'll be able to cover some of the topics that I do think are going to affect everybody's clinical practice and challenge. And I guess I'll start with you, Brahmajee. What kind of things did you see today or yesterday that you think are really sort of important for people at home?
Yeah, no, so a lot of great clinical trials. These are, really like practice-changing trials. You know, I know we're both sitting in the interventional cardiology world, so I'll probably start with that. There was a wonderful session this morning that covered, you know, 3 big topics with 4 clinical trials. I think the broadest trial was a couple of studies that looked at the use of angiographic-based FFR assessments. There was the All-Rise study and the FAST-3 study, and in many ways these studies were kind of parallel. They used 2 different types of technologies and showed that using these angiographic-based tools for determining FFR seemed to do as well as wire-based methods. There was a little bit higher use of stents and treated vessels with the angiographic-based FFRs, but overall the outcomes, clinical outcomes, were the same in both groups, and each trial had a couple of thousand patients in it. So I think there's a lot to learn from this, so we'll have to see what happens. I think what'll be interesting is how these tools get deployed. I think that there's a learning curve that's going to be, you know, necessary for their use, but they could really change the paradigm about how we do revascularization in the cath lab.
Oh, I think so. And I think that, you know, as the interventional field, as you know, and we've thought about, has matured over several years, from even the simple things about asking for indications and making sure we know the ischemic burden, to the athero burden, to physiologically guided revascularization, to now I'll call it sort of lane assist, making sure we see which vessel is where and we're not missing places where there might be significant physiologic problems, or we're not overthinking or saying, well, maybe we need to test that before we stent it. So in some ways, we continue to mature, and those 2 studies, I think, help us get to the next level of reducing, I'll say, variation in a place where you could make sure you're getting the best outcome for our patients.
What about you? What have you seen so far?
Well, lots of interesting blockbuster studies. You know, I guess I'll start with one that I think probably a lot of people are hearing about or talking about. It's the Champion AF study. Just to remind everyone, this is important, and a series of studies that are now occurring with left atrial appendage closure compared to anticoagulation in our patients with atrial fibrillation, just to sort of set the stage. It's now, I think, about 15 to 16 years since the first set of those new, and I was involved in some of those direct-acting oral anticoagulant trials, actually moved the field for patients with atrial fibrillation and reduced stroke. And there's still a risk of bleeding, and there are unfortunately patients who still don't tolerate that and need other things. In that background, left atrial appendage closure was actually studied against warfarin and anticoagulation and demonstrated at least to meet some efficacy effect of saying there's some ability there. Although, you know, there was always questions around how do they compare to NOACs or DOACs, if you will. In the last few months at AHA last year, we heard of the Closure AF study, which was actually an important background to this study, where investigators in Europe randomized patients over some period of time, a little bit higher CHADS-VAS than what we saw in Champion, a CHADS-VAS score of 4 or 5, and those patients got an endpoint for non-inferiority that included bleeding, both peri-procedural bleeding and all bleeding, and then also looked at stroke. And there, you know, it's kind of funny when we think about Closure AF before we think about Champion. There, the finding was that the event rate was higher in the left atrial appendage closure arm, so that it did not meet non-inferiority, or was not inferior, a funny sounding way of saying it didn't meet it. And in that background, then it was really much anticipated that the Champion study would be presented. And I thought, you know, it's an important study, another non-inferiority study in which, for, you know, I would say 3,000 patients, or about 1,500 in each arm, got the device or anticoagulation, and they were followed for some time to see if they had a stroke, if they had bleeding. Now, this is a non-inferiority study, so just to remind our audience, non-inferiority means you're within a certain percentage or a certain band of the predicate therapy or DOACs here. And the patients here were Chad's VAS score was reasonably elevated, 3.5. Interestingly, the HAS-BLID score wasn't very high. They were about 71 years old. About 32% were women. And so here, I think this is a population of patients that were probably with AFib some risk. One unique thing, I think, importantly, the patients here had an ablation, 40% of them, not all of them, but 40% of them or so had an ablation and then got the closure device at the same time. And I think as we are learning in the field, the active ablation might be lowering people's risk because now they're not in his AFib as long. And so one of the take homes for me is going to be decoupling those two procedures, because what we saw in this trial, again, was that the event rate was low. In fact, the overall event rate and the primary efficacy endpoint, just to be really specific about that, that was, again, a composite of death from cardiovascular causes, stroke, or systemic embolism. And that was tested for non-inferiority with a margin of 4.8 absolute percentage points, so that, when the observed event rate was 5.7, that event rate was lower than anticipated, but the non-inferiority margin was almost as great as they observed. So it was almost not possible, unless it doubled it, that you wouldn't think that this was going to be non-inferior. And so then it becomes, what are the trade-offs and how do you engage with patients? Because what were the actual observed rates? And here again, I'm a little bit, I was given a little bit of pause because the ischemic stroke rate was higher with the closure device, and that gave a hazard ratio of 1.6. But the bleeding rate, the hazard ratio was 0.5. So I think this is, it met non-inferiority. And I'll say what I've been saying is, and it was informative. Sometimes non-inferiority is not informative, but it depends on how you use the information. For me, in my clinic and practice, I'll likely go back and still have a reasonably high threshold to be referring patients for left atrial appendage closure, I'll say, because there is some peri-procedural risk there. There is a higher ischemic stroke risk. There's less bleeding, and that's important, about 50% less bleeding, and that is important. And I would say it has two things for me to teach. One is that if you're on a DOAC, half the bleeding you see in some of these patients may not be related to the DOAC. It may be to the patient. And so you can get rid of half of it, but there's still some there. So when I go to my patients and tell them this is going to be a strategy to reduce bleeding, it'll reduce some, but there's going to be some other bleeding and even peri-procedural that we haven't talked about. So I do think for some patients who don't want to be on blood thinners for a long time, as they say, and they want one procedure and adherence can be an issue, it could be a conversation. But I don't think it's going to be as easy as most of my patients are going there. I think the world is really changing on these event rates in these patients. What'd you take of it? Because it's gotten a lot of conversation here.
No, well, I can tell you, listeners are going to really appreciate your thoughts, because you've been in this space for quite a while, and I really enjoyed hearing your take on it, because it is very complicated. I think you're right. I think one of the things that's coming out of this is just all the attention now on non-inferiority trials. I mean, they're growing in the cardiovascular space, and I think we need to have a better understanding of them and what they mean, and when maybe you should look for both absolute differences and relative differences. I think the discussion around the meeting has been really exciting in that way. Like most things, I love how you said that, right? That this trial is informative. I think it does give us some new basis of knowledge, and in many ways, this is where the crux of medicine. This is why medicine is so important, but then also so challenging, right? I mean, this is where shared decision making is going to play a big role.
I think so. And when I say it's informative, I think it's informative for shared decision making, because I think what might have been like, oh, well, it's such a big winner, we just go. That's not the case. It's going to be something that I still think is going to have to be a very careful conversation for patients, because DOACs are still performing pretty well for stroke prevention.
Yeah, they're good drugs.
The procedure was done well in the study, and I think a lot of patients are potentially candidates depending on where they are, but that's where this information will help have that conversation. Well, that was left atrial appendage, and we talked a little about angiographic stuff. What about Impellas? I know you wrote the editorial in the New England Journal, and there was a BESIS-3 study, I think, on high-risk PCI, and then also Impella in unloading. What's the take there? What do we find out?
Two wonderful studies. I'll go a little bit deeper in the CHIP BESIS study. It came out of the UK, Devaka Parari is the first author. And once again, I'm a little bit jealous of like the ability of like the UK to answer these like fundamentally critical questions for us around devices in the cath lab. They did a wonderful job. They randomized 300 patients to the use of a microaxial flow pump support, the Impella, largely the Impella CP, during high-risk PCI. And the way they defined high-risk PCI was they said PCI that, was done in individuals who had an EF of 35% or less, also multi-vessel. These were like high-risk cases when you looked at them, right? Like about 80% of them involved the left main, like true bifurcation type disease. About 80% of them required some type of atherectomy or plaque modification. And the study was like incredibly well done, very meticulous, and they looked at outcomes. They followed people for at least a year, but I think the median follow-up was about 22 months in the study. And the bottom line was using a win ratio with a hierarchical endpoint set. So, cardiovascular or actually overall death was the highest. And then it kind of went down towards, other types of important outcomes and ended with paraprocedural injury. Everything seemed to favor the use of a conservative approach. And a conservative approach in this case wasn't a balloon pump or some other type of supportive device. It was literally nothing, with a bailout only reserved when needed. Very few patients actually ended up getting bailouts. And so that was an interesting kind of finding as well. I think, it's so fascinating when you think about this, right? Part of it is that the use of these devices has been kind of labeled as protected PCI. That's a common kind of term in discussion. You'll see sessions on it at our meetings. I think what it left me with was this really interesting understanding, because, all of us who practice interventional cardiology, we get nervous when we do these cases, right? Because things can go south quite quickly. And having this type of device as support is something that we've oftentimes relied on. But it all comes with a price, right? There's a price to this idea of protection. Yeah. These are big devices. You can have vascular complications. You can have bleeding complications, all sorts of things. So balancing that out, it again gets to the crux of medicine, right? Like, is that advancement in treatment worth the risks associated with it? I think that this will have an impact on clinical care. I will say this: what's kind of remarkable about this device is, since it's been approved for high risk PCI, its use has increased dramatically in the U.S. In fact, like, use of this device in the U.S. for high risk PCI support is about 40 times what it's used in other countries like the UK. And I think we need to kind of stop and really think about that, largely because if you look at the secondary outcomes, the signal was towards harm, right? Like overall death, higher rates of cardiovascular death. So it's really going to be an interesting viewpoint. Now, the nice thing is we do have Protect 4, which is enrolling right now. That's going to have 1,200 patients and will hopefully help us understand what are the types of patients in which these devices can be helpful, and when we maybe should back off a little bit. Without spending a lot of time, the STEMI door to unloading time also was done, and that was really interesting as well. For that, it was like looking at infarct size with the use of Impella. The Impella was placed, and then there was a 30-minute window before reperfusion was definitively performed with primary PCI. But there was no change in infarct size. So again, this animal model based idea that unloading the ventricle prior to primary PCI might increase myocardial salvage doesn't seem to have met that outcome.
Two great summaries there. Thank you. And I think really important to think about how the field is evolving and the rigorous science for these devices that we just went through. We've talked a lot about interventional studies, but there was really some really important and good science around preventive therapies. In fact, maybe the one that I think probably affects the most lives, or at least some of the most lives, is Ez-PAVE, which was an intensive LDL cholesterol targeting in atherosclerotic cardiovascular disease. And, this is on the heels of just having our lipid guidelines come out with changing the target from secondary prevention of patients getting their LDL below 70 to below 55. And I can imagine, my wife's a primary care doctor, and I was like, oh my gosh, this is going to even be harder. We got a lot of patients to talk to. How do we do this, right? So a lot of real energy to say, where's the evidence? Now, we saw VESALIUS already at AHA with a really high-risk primary prevention goal of showing people that got down to 40 made a difference in them, and certainly that's important. But this is even maybe a little bit stronger evidence, because it was actually a randomized trial. In again, jealous of sometimes how fast and how well some of our colleagues do these trials. Our South Korean colleagues doing secondary prevention lipid trials are really powerful. They randomly assigned in an open label fashion the target of getting somebody's LDL less than 55 compared to less than 70, and they actually had somewhere around 3,000 patients, about 1,500 in each arm, and they followed them for 3 years. So sort of precedent thinking, the guidelines are asking different things at that time. Let's go randomize and find that if there is a difference. And they looked for the primary endpoint, I think, important to most of us, cardiovascular death from cardiovascular causes, non-fatal MI, non-fatal stroke, any revascularization or hospitalization for unstable angina. So sort of pretty big composite, but important, looking at any of those cardiovascular events. And they were able to get the people in the mean goal of 55. They got the people to 56 milligrams per deciliter. And for the other group, they got them to around 66. So the difference between 56 and 66 was statistically significant for this big goal. The hazard ratio was 0.67, and it was like 6.6% at 3 years in the group that got the lower goal versus 9.7. So in people with secondary prevention and atherosclerotic cardiovascular disease, a really powerful, I think, strategy study showing and supporting where our new guidelines are, that the LDL less than 55 or targeting getting to 55 leads to better outcomes. In clinic, I've for years now started to say, there's no number too low. We try to go as low as we can, and we try to keep it as low as long as we can. But this is, even more confirmatory data to help us there.
I couldn't agree more, Manesh. It's interesting because it was almost like, for that level of LDL lowering, the impact on cardiovascular outcomes was quite dramatic. But I think, when you look at the whole, scope of literature out there, and VESALIUS, like you mentioned last fall, I think really added to that. I think this is all just pointing towards, again, supporting what the guidelines are doing. It is interesting. Also at this meeting, the VESALIUS diabetes subgroup was presented too. Again, findings very consistent within that group as well. So I think we are starting to kind of think through like how we can kind of approach patients. And what's wonderful is, if you compare to 20 years ago, the amount of the armamentarium we now have to really deal with risk prevention is just it's staggering. And so it's really exciting, really just improving patient outcomes overall.
Yeah, I think it is. And, I'll add one more. I know we're going through a lot of studies. I'll add one more that I thought was really important, which is was published in Nature simultaneously, which was, DASH pattern groceries and effects on blood pressure in adults who are treated for hypertension, and it was the GoFresh RX randomized trial. And here it was really interesting because, DASH diet has been shown to lower blood pressure in Black adults. And this intervention obviously is something that we aim to do in multiple ways, but they conducted a randomized clinical trial to test whether local groceries ordered with the assistance of a dietitian to align it to DASH diet might lower blood pressure among Black adult residents of Boston communities. And those were in communities where there were few grocery stores and they were actively being treated for hypertension. So sort of this idea that there are these deserts of places where unfortunately people can't get as much groceries or fresh groceries or DASH-like dietary food. And they were individuals whose blood pressure, they're people who had obviously hypertension with blood pressure above 120, but less than 150. And they were actively randomized to either getting that DASH delivered groceries with dietary counseling or receiving $500 stipends every 4 weeks. So actually giving them money to go get groceries or food, but recognizing they're going to take away some of that difficulty in education by getting it to them. And the primary outcome was not just the blood pressure at 3 months, but they also looked at other measures. And it was really impressive to me. I mean, that they did this outcome, and they were able to show that they had most of the people, and these are people that they had 176 people, and they're mean age 60, and they randomized, and about 80% were female. I think that's really important. And 173 of those 176 patients had their blood pressures measured at 3 months. And at 3 months, it's about 7 millimeter reduction in the DASH grocery group versus 2 millimeter reduction in the self-directed group. So a 5 millimeter absolute difference. And that I think is powerful and sustained. You saw a little bit of it go away at the end, but the nutrition target stuff still stayed for a few months after. So, it sort of opens up an important part of our kind of armamentarium that American Heart and others are doing with food as medicine, and ways in which we start to study how we can improve. And remember, all the medicines were kept the same. Otherwise, people are doing everything else they do in life, and so it's getting DASH dietary and dietary information, I think. And I think that education and probably that intervention also stayed a little bit, as we saw people when they came off of getting that, still having their blood pressure potentially better managed on the medications we have. So it's sort of a new era in how we think about prevention. Obviously, scaling and being able to do this in lots of different communities is going to be an issue, but I found that really important study in a way that I think we haven't thought about potentially some of the things we could do in the past.
I think it's a great example of, you had mentioned the food as medicine programs that are like popping up, and just such an effective way. And all of us who've kind of been in this space realize how hard it is to do these types of real world studies. And so for Stephen Juraschik and the team to be able to pull this off in Boston was quite impressive. So I think there's a lot to learn there. Obviously, the question is going to be what you had mentioned, which is how do you scale this across different communities? But potential here is just going to be really exciting to see.
Well, I mean, we covered cholesterol, a little bit of blood pressure. We talked about the dietary work. We talked about the LDL, left atrial appendage closure, angio versus invasive wire FFR, and some of the microaxial flow pump. I mean, we've done a tour of most things across the space. I guess the last one, I think maybe, we were, I think, again, opening up new areas where we didn't talk a lot about heart failure therapies and stuff, but mavacamten for obstructive hypertrophic cardiomyopathy was actually presented here in a unique, I shouldn't say unique, but often understudied population, a phase 3 double-blind randomized controlled trial in adolescents that you were highlighting for me. 44 patients got randomized, 23 of them got placebo, and 23 got mavacamten, and 21 got placebo, and they were able to show a reduction in the gradient for a hypertrophic cardiomyopathy in these patients, which I think is going to, be a really important finding, along with the consistent safety message for a population that doesn't usually get studied. So another sort of rounding out the places that we're learning about things in cardiovascular medicine.
I think it's so interesting how you can learn from these small studies, especially because, these are patients that we come across, right? Our colleagues, especially in the hypertrophic cardiomyopathy space, this is some real world choices they have to make. Another one that's like kind of a small, but I think powerful study and message was the ORBITA-CTO study, right? Again, it was 50 patients.
Yeah.
That study has gotten a lot of discussion too, but they were able to show that a CTO procedure compared to a placebo-controlled, procedure where everyone got double access, they got a prolonged placebo-controlled environment procedure. Blinding was maintained, and they showed that actually there is a reduction in the Orbita Angio score after revascularization of their CTO. Now, there's a lot of critiques about this because it wasn't compared to aggressive optimal medical therapy in this population. But I think, like most studies, I think, again, getting back to what you had said earlier, it helps inform some of these complex discussions that we oftentimes have with patients. And really, I think it's just going to, increase our ability to kind of improve on shared decision making and really just help move care forward. So I'm kind of excited about that too. But again, a great example of like how these small, powerful studies can really guide us as well.
I think, again, Arasha and her team are continuing to show us good science and the way to do it. So I think we all want to continue to do that. And again, great interventional data coming from some of those places. Well, look, this has hopefully been a really exciting review for you all. I mean, I will tell you, it's exciting always to have these meetings, and we're excited to see the field continue to move forward, where we hope that these great discoveries get to everyone where they need them everywhere. Part of the missions of the American Heart Association and our societies to get our patients better health. It's been fun going over these with you. I do hope that Duke and Michigan meet each other soon in another rematch, and we'll see how that goes. And then I would say for all of you at home, if you weren't here, we're sad you couldn't make it, but get ready for the American Heart Association. I know you're playing a role in the sessions in November, and I'll have an opportunity to be, as the incoming president, really excited to be there. So we hope you all will join us. And Brahmajee, thank you again for doing this recap with me.
Thanks, Manesh. It's been great. And yeah, we'll see you all in Chicago.